he may not remember this, but I was in the front row at the hotel in Santa Fe, the El Dorado, when ACMA, the American College of Mental Health Administration, had you as the keynote speaker, and you gave a really extraordinary talk and very inspiring about healthcare integration and such. And I'm so glad that you're able to join us now, all these years later. That was 2007. Not to make myself look old here, but so Dr. Satcher, for those of you who don't know, MD, PhD, is a physician, scientist, and public health administrator with an extensive track record of leadership, research, and community engagement. He's a Phi Beta Kappa graduate of Morehouse College and holds MD and PhD degrees from Case Western Reserve University, where the debate's going to be tonight, I believe, and where he was also elected to Alpha Omega Alpha Honor Society, excuse me. Dr. Satcher served as the 16th Surgeon General of the United States from 1998 to 2002, and the 10th Assistant Secretary for Health in the Department of Health and Human Services. He also served as Director of the Centers for Disease Control and Administrator of the Agency for Toxic Substances and Disease Registry. We're going to be very interested in your comments, certainly about disease control this morning, Dr. Satcher. Dr. Satcher has also held top leadership positions at the Charles R. Drew University for Medicine and Science, Meharry Medical College, and the Morehouse School of Medicine. He has received over 50 honorary degrees and has received numerous awards from diverse organizations and agencies. Currently, he's the founding director and senior advisor for the Satcher Health Leadership Institute at the Morehouse School of Medicine in Atlanta. In 1999, he issued Mental Health, a report of the Surgeon General, first report of that kind from a Surgeon General on our community and our issues. Finally, his comments were recently featured in a recent article in The Hill entitled "Failure to Address the Coronavirus Mental Health Issues Will Prolong Impact." And his Satcher Mental Health Leadership and the CDC Foundation are in the process of establishing a health equity task force that will address the disparate impacts and underreporting of the impact of the virus on racial ethnic minorities, people living with disabilities, and those of lower socioeconomic status. So with all of that, it's my great pleasure on behalf of the NYAPRS board, our staff, and our entire community to join you, to welcome you today, Dr. Satcher.
Well, thank you very much for that very kind introduction, Harvey. It's great to see you again and to be with you. I had an opportunity to listen in yesterday to a couple of your sessions, and I must say I'm just honored to be a part of this conference. I often think about COVID-19 and all of the problems that it has caused us, but I also realize that some things are happening that would not happen if it were not for COVID-19, so I try not to complain too much. But I'm certainly very happy to be with you, to be able to be in my office here at the Morehouse School of Medicine, and at the same time, to be with so many of you in this conference. We share a lot of concerns. When I released the first ever Surgeon General's report on mental health, there was a lot of history behind that, personal history, family history, community history, and having felt for a long time that this was an area that deserved much more attention and a group of people who deserved much more concern and consideration. In fact, I was thinking last night, it actually started when I was a medical student at Case Western. And a lot of things happen to you when you're a medical student, especially if you are the only Black student on most of your rotations. And that was an experience that I had quite a bit of. But anyway, we went on the first day of the behavioral health rotation. Case Western didn't call it mental health, they called it behavioral health. But the first day, We were going around seeing patients, so they were being introduced to us. And then we got to one room, and the faculty member said, well, we're not going to be able to go in to see this patient because he tends to be violent. And it turned out he was a 17-year-old black male, and he had been there for some time, and they had said that he was probably going to be sent to the state institute because they didn't think they could do much for him. When we left his room, I asked the faculty person if I could go back to see the patient. And he said, well, you know, I told you, David, that this patient is violent, and that's why we didn't go in. I said, yeah, but I would just like to go back and see him and talk with him. And he said, okay, well, then if the nurses agree and I will let you in, it's fine with me. So the nurses agreed. I went back to see him. The first day I saw him, he attacked me, but I was able to defend myself adequately. He, in fact, he wanted to know, where did you learn to fight like that? And I said, well, I wasn't fighting, I was just defending myself. But then I told him that when I was a student at Morehouse in Atlanta, I had been a part of the student movement. And I explained to him that it was a nonviolent movement that had been started by Martin Luther King Jr. in Montgomery bus boycott. And the students in college now were adopting this strategy to protest discrimination. He was very interested. I mean, it's like he hadn't heard anything like that before. And I explained to him that we felt that you didn't have to be violent to make your point, and that we often made our point without getting violent. But to make a long story short, I went back to see him several times, and we sort of became friends. He was very interested in my past. Told him about Alabama. I told him about what we couldn't do there, including buying an ice cream cone, you know, when you were 5 years old, because they didn't serve blacks. So we became friends, and he became very, very interested in where I had come from and where I was going. And I think because of that, he agreed to take his medications. The nurses were very pleased. And after a while, he was actually able to go home. I'm only saying that to say that it makes a difference to have a positive experience with the patient. I know that many of you have had that experience where you get a patient who's very difficult, and somehow you're able to work through your difficulties and to move to another level of interaction. So I had a positive experience in behavioral health because of this patient and the way he responded. In fact, the faculty member was so impressed that he asked me if I would do grand rounds in behavioral health. This patient was paranoid schizophrenic, and the faculty member wanted to present that. I didn't know until later that he wanted me to do the whole thing. I thought he meant that he wanted me to present the patient and he was going to talk about the problem. But so that was my first experience. And when people ask me, why did you do Surgeon General's report on mental health? It has a lot to do with that patient and the fact that I was fortunate enough to have a positive experience with that patient. I wanted to give you that background, but I also wanted to take a minute and say that, I wanted to take a minute and say a little bit about COVID-19. As you've heard, I had the opportunity to serve as director of the CDC for 5 years, from 93 to 98. And it was quite an experience. And I encountered a lot of epidemics, pandemics during that period of time throughout the world. Had an opportunity to work with India, for example, and to virtually eliminate polio. I'm sure most of you know that when you say eliminate in public health, it's not the same as eradicate. We've eradicated smallpox disease, which means that there is no smallpox disease anywhere in the world. So we set out to eradicate polio when I was director of the CDC. I remember spending a week in India. Our goal was to immunize 100 million children in India against polio. And because if we could do that, then we would be very close to eradicating polio in the world, because then we'd have to worry about maybe Nigeria, Afghanistan, Pakistan. It took several years to eliminate polio in India, and it happened long after I had left the CDC. But even today, we can't say that we have eradicated polio, because there are still cases of polio in Afghanistan and in Pakistan. There are no cases in Africa. Believe it or not, one of the major places with polio, Africa has no cases of polio today, just as India has no cases of polio. So we've had success in two major countries, but we haven't eradicated polio, because as long as there's one case of polio in the world, it has not been eradicated. I'm saying all of this, and I know most of you know it, but I'm saying it anyway, because I always think that the high point in the history of public health was probably the eradication of smallpox disease in the late 1980s. That was before I became director of the CDC. If you've heard names like Donald Hopkins and several others like that, then you know that Donald Henderson and other names that I can't remember right now, but they were outstanding public health leaders and led the way with the WHO in eradicating smallpox disease. And hopefully polio will be the next disease eradicated. So COVID-19 is by no means the first pandemic. And most people know that about 100 years ago, the so-called Spanish flu had a major impact on the world, including our country, until it was eliminated. I didn't say eradicated, but eliminated. So we've had a lot of experiences with outbreaks like this. In fact, when I became Surgeon General in 1998, one of the first things that I was asked to do was to go to Philadelphia as a part of a 200th anniversary of a major yellow fever outbreak that took place in Philadelphia and actually resulted in the death of more than 10% of the population. But more than that happened, because President John Adams was there in Philadelphia, because the White House was in Philadelphia at that time. He decided that there needed to be some permanency about our response to a public health problem like yellow fever. And so in Philadelphia, in 1798, we started the first public health program, more than 200 years ago. And that has, many things have happened. Of course, we've had several hospitals, and I visited the key ones that have been in a position that when our soldiers come back from the war front, these hospitals were set up to treat them. But it continues to be a real challenge. If 1798 represented the beginning of public health. A few years later, before the first Surgeon General was named, the first Surgeon General was around 1781, but we've had a total of about 21 Surgeons General in the country. There have been several reports issued, and yet when we released the report on mental health in 1999, that was in fact the first ever Surgeon General's report on mental health. I don't feel good about the fact that that was the first ever. I do feel good about the fact that we finally took on mental health, and I think we have stayed the course in many ways in trying to make programs more relevant to the needs of people with mental disorders. And more importantly, as I think Harry may have said yesterday, more importantly, we now view mental health, we should, as a part of our overall health and well-being. And so our attitude toward mental health is that we should be prepared to deal with mental disorders whenever they come up. Now, we're not there yet. Many people with mental disorders are still treated as criminals. And we used to say when I was working in Los Angeles that that the largest mental health institution in the country was probably the Los Angeles County Hospital. I'm sorry, the Los Angeles County Jail. It would be great if it were a hospital, but it was the jail, because so many people with mental disorders were arrested, were put in jail as if they were criminals, and in many cases they were not. They were ill and needed treatment. I'm very pleased with the fact that many judges have today decided to sentence people with mental disorders to treatment and not to jail. So we've come a long ways. We have a long ways to go. I've gotten to know a lot of people on this road, as Harvey pointed out, met with a lot of people, worked with a lot of people. And yet as we gather here today, we still have miles to go before we sleep. I'm going to take a few minutes and say something about COVID-19, but I want to integrate something about the Satcher Health Leadership Institute in that discussion. Let's look at a few slides that will help with that. Okay. Go ahead. Can you see the slides?
Not yet.
You need to go.
No, we can't see them yet.
I have some great help here, so we should see them soon.
No problem. I'm using the time to write up all my questions for you, Dr. Satcher.
Okay. Well, that's good. I love questions. I don't always answer them, but I love them.
Me too.
Yeah. But there are mental health challenges involved with COVID-19. And that should be clear, because if we're not aware of the mental health challenges, it's highly likely that we are not appropriately responding to them. So I wanted to take a few minutes and to talk about some of the mental health challenges. But first, I do want to do a better job of introducing you to the Satcher Health Leadership Institute. This is, the next one. The mission of the Satcher Health Leadership Institute is very special to me. We started the Institute in 2006. I had actually served as interim president here at the Morehouse School of Medicine. And as opposed to going back to my position of director of the National Center for Primary Care, I decided that the guy that had replaced me there on an interim was doing such a great job that I would be doing an injustice to go back and replace him. So I asked George Russ, whom some of you know, to stay on, and I decided to start the Satcher Health Leadership Institute. The mission of the Satcher Health Leadership Institute is to develop a diverse group of exceptional health leaders to advance and support comprehensive health system strategies, and that starts with parents in our program, but also to actively promote policies and practices that will reduce and ultimately eliminate disparities in health. Some of you may remember, I think it was around 1990 that we started to discuss the reducing disparities in health. There was a big discussion about disparities in health among different racial and ethnic groups, and the decision to begin to work to reduce those disparities. Well, in the year 2000, 2 years after I became Surgeon General, we changed the language, and there were only two goals in Health to People 2001 was the goal of improving the quality of life for people as they got older. And I appreciate that now much more than I did at the time, as I've gotten quite a bit older. But anyway, that was the beginning of the goal of eliminating disparity. The next goal was eliminating disparities in health. And that was the next goal. Since that time, I think we've made progress, but we still have miles to go before we sleep. So one of our mottos at the Satcher Health Leadership Institute is that today the need for leaders is too great to leave their emergence to chance alone. So we set out to help people to develop their leadership skills. That was in part because when I was interim president here, I decided that the next time there was a leadership vacancy, I didn't want the board looking to me to fill a gap. So I decided that we needed to start developing leadership skills in other people around us. And so that's how the Satcher Health Leadership Institute started. We have had probably 1,000 people to go through here now, including about 100 physicians. We've even had over 80 lawyers because we believe that we need to develop community health leadership teams. And so we've had lawyers, we've had pastors of churches and communities. We've had parents, young parents, who want to improve their parenting skills, but also to provide leadership in the community in terms of bringing parents together. And so we followed through on our belief that the need for leaders is too great to leave their emergence to chance alone. Okay. Okay. So today, we have these 4 reports that have been released by the Office of the Surgeon General on mental health. And these happen to all have been released during my tenure. The first one there, as you see, was Mental Health, a Report of the Surgeon General, 1999. And then in 2001, we released a report on children's mental health. I wish I had time to tell you how important that is, because I believe the most important time to intervene in mental health problems in one's life is very early. But because of our attitude toward mental health, we often ignore it in children, and so they don't get the support, the treatment they need. A lot of parents, of course, are very hesitant to even admit that their children need help. And so often the children don't get it. And I think we got to change that. And I think we can. We're making some progress. Our next report was mental health, culture, race, and ethnicity. And again, it had to do with the fact that there are differences in terms of culture, race, ethnicity, in terms of how mental health impacts individuals and how mental health impacts communities. So mental health, culture, race, and ethnicity was about those differences. Mental retardation was something that didn't quite fit here. I think it's here because we had a special project. Don't get me wrong, I think mental retardation is an issue that we should all be concerned about and involved with, but I don't think we should lump it in the same bag with some of the other mental health problems. But we did a report on it. I want to pause and ask you the question, how do you define mental health? What is mental health? And this is what we came up with, and I feel pretty comfortable with this definition. We said it is the successful performance of mental function, resulting in productive activities, fulfilling relationships with others, the ability to adapt to change, and to successfully cope with adversity. So if you break that definition down, there are four very important components of it, I think. One is one's ability to be productive in his or her activities. That's very important, as you know. That's why many of you are here today at this meeting, because you have been productive in your area. You've been so productive until you have something to share. The second component of that definition is fulfilling relationships with other people. Yeah, easier said than done, right? But that's important. That's not a selfish goal. It says that it's bilateral, that relationships are fulfilling to the partners involved. And it may be more than two partners in terms of these fulfilling relationships. No, I'm not just talking about sex. I'm talking about relationships. The other important component of the definition, I think, is adapting to change. So what about COVID-19? I have to admit to you that I was not ready for the changes that I've had to make in my own life, and that in my family, I don't, I used to see my grandkids every weekend, and now it's maybe once a month, but their parents are very concerned about, the spread of this virus and avoiding it, and I understand that. But COVID-19, in addition to its many different problems, has created a problem for relationships and for families. And it's important. Don't get me wrong. I am a very strong supporter of wearing masks. I'm a very strong supporter of physical distancing and things like that will reduce the risk of spreading this disease. And I could go on and on, but I just think that prevention is much more important in this case than the other things we can do. Those of us who have not gotten infected with COVID-19 are fortunate, because I know a lot of people, good people, healthy people, strong people, who've gotten infected with COVID-19, and many of them physicians, many of them nurses, and I've watched them get sick in many cases, and many of them have passed on. So this disease, COVID-19, is nothing to play with. It's very dangerous. It's already killed 200,000 people plus in this country. And we're one of the top 4 countries in terms of this disease. And so we all should take it very seriously. It's a very serious disease. I could talk about it, but I know that you don't need me to repeat what you've already heard about COVID-19. Here at the Morehouse School of Medicine, we decided to open up because we felt that it was the best way to deal with our students especially, and to, as long as we could maximize safety, as long as we could optimize their learning, and also prepare them for the epidemics that they're probably going to face in their life. And so we have been open since the beginning, but we have also been very diligent about people wearing masks. The only time you'll see me without a mask here on the campus is when I'm talking to you like this. And we feel very strongly about the importance of protecting people against this virus. And still, there is so much that we don't know about this virus. I don't know what happens to people 10 years later, 20 years later. I know that several people who get the virus recover from it in short order. But I also know that several people who get the virus don't recover. And several people who thought they had recovered go on and have problems later. We're learning this as we go. There's still so many things that we don't know about COVID-19. The last component of this mental health matrix is to be mentally healthy means that we are able to successfully cope with adversity, including COVID-19. So many people have struggled being, quote, trapped at home, families, and there are debates about the importance of school. And I happen to believe that school is very important. If you read my report on dealing with mental health in children, then you know that I feel very strongly that school is an extension of our program of intervention and treatment for children. It's a part of keeping them mentally healthy. Many children who go to school get their only good nutrition at school. There are other children who are only able to be physically active safely at school. And so school is important. It's much more important in the lives of some children than others. And we should admit that as we deal with this problem and others. So that's what we meant by mental health when we did the report, and that's what we still mean today. So there were several key messages, and you probably don't need me to go over those, but I will go over them. I know that, you know, we're still learning. We're learning from you and others. Soon after we started the Satcher Health Leadership Institute here at the Morehouse School of Medicine, we became concerned about how mental health problems were being dealt with at Grady Hospital. And now Grady is a public hospital. It's one of the largest hospitals in the country. I think it's in the top 5. And when we started, we did something that I have a habit of doing, and that if I believe that one way to succeed is to find a need and fill it. You've heard that before. But if there's a need that you can fill, then people are going to view you, even though you're new, calling yourself the Satcher Health Leadership Institute. But if you can fill a need, people take you seriously. So Grady had a problem in its emergency room, and patients who were coming into the emergency room with mental health crises of one kind or another, they may have attempted suicide, they may have been disorderly or what have you, but they needed treatment. And many of them came into the emergency room, and some of them would wait there for up to 10, 12 hours waiting for the psychiatrist. And so we made a decision that we should take over mental health treatment in the emergency room at Grady Hospital. Luckily, people here trust me a lot, or they wouldn't have agreed to that. But we did. We decided that we were gonna take over mental health emergencies, and we did. But we decided that when a patient comes into the emergency room with a mental health challenge, they needed attention soon. They may not have been able to see a psychiatrist right away, but we felt that mental health was delivered by a team, and the members of the team were trained. We could provide some valuable service to people in the emergency room, while on the other hand, they would have been just sitting there waiting and trying to figure out what was happening in their lives. So we did that. We trained people to intervene from the time a patient came to the emergency room until time they were, quote, officially seen by mental health specialists or what have you. We had a team. We had the social workers, the educators who were working together. And to be honest with you, providing probably better care than these patients had ever received. So it was that, and this was written up in the Journal of Emergency Medicine. I think it was written up about 8 years ago. But it was something that we did. Forgive us for the cell phones acting up. But we did take over that responsibility. We volunteered for it, and we made a difference. And people started to take the Satcher Leadership Institute pretty seriously, because these guys are either crazy or they are willing to do some things that need to be done that other people won't do. And so our status changed in the community in terms of the value. There were other things like that. I just gave you that one example. There were other things that we did that were needed, and yet nobody was doing. And I know many of you do that every day, and I commend you for that. We need more people still, however, who are willing to fill the gaps in our health care, especially in the care of people, in the care of communities. Mental disorders are disabling, and that should be said loudly. They are disabling. They are as disabling as cancer or heart disease in terms of premature death and lost productivity. You may have to think about that a minute. I've thought about it, and I know it's true, but it's not the kind of thing that you can say lightly. Mental disorders are as disabling as cancer or heart disease. Excuse me. And I was actually surprised the first time we dealt with these numbers, but life expectancy of people with mental disorders averages out to about 25 years less than the rest of the population. Now that includes our veterans coming back from the war front. And there are many reasons, including suicide being one of them, that the overall life expectancy, using that denomination, is averages out to about 25 years less than the rest of the population. Serious that we're not dealing with that. Mental disorders are common, especially in the United States, but all over the world. But we know what the data look like in the United States, that 1 in 5 Americans has a diagnosable mental disorder each year. It's a lot of people, 44 million adults and almost 14 million children suffering from a diagnosable mental disorder. So It's something that we cannot take lightly. But there's good news. I always look for good news. We need good news. And I know you've been looking for good news when it comes to COVID-19. And despite what anybody says, including the president, we haven't had much good news yet. But we can. If we admit where we are, we can have better news. Research has improved our ability to recognize, diagnose, and treat conditions effectively. And many of you have been involved in that, so I know that you agree that we made progress in being able to recognize mental disorders, to diagnose it, and to treat it. And that 80 to 90% of mental disorders are treatable using medication or other therapies. So we can help people with mental disorders. And there's no excuse for people being put in jail when they're not guilty of any crime and when what they need is treatment. There are a lot of ways we can help them, and I know that many of you are on the front lines of doing that. But of those with diagnosable mental disorders, this is the bad news. Fewer than half of adults get the help they need. And even fewer children. Only 1/3 of children get the help they need. That's the reality that we're dealing with today. You are helping to change that. We can help to change that. And hopefully we will continue to work until we have created at least that situation. I've talked a lot about stigma in my career. It deters treatment when it comes to mental illness. Individuals who have a problem sometimes are unable to acknowledge it because their experience has been that if you acknowledge that you have a mental health problem, you're going to have trouble. You're going to have trouble getting a job. You're going to have trouble getting friends. So people just don't go around every day admitting that they have a mental health problem and that they need help, whether that mental health problem is depression or whatever. I'm happy to see that some of the, I believe, pharmaceutical companies now have advertisement for their drugs. And they have included people with mental health problems in those advertisements. And that's a good thing because people are able to express, themselves and how it feels to have certain mental health problems. Stigma also affects families. I've had that experience in my own family, and many of you have had it. I didn't know what was going on with some relatives when I was growing up. I just knew that people whispered about certain people as opposed to talking about it. We've made some progress, but we still are struggling to make sure that people get the help they need. And then there's policy. We have policies that are stigmatized. I think that's the best way to say it. That is, there are certain policies in terms of the way we treat people that are based on stigma, on the stigma that we have in our minds about people with mental disorders. And so we can't afford to continue those policies. But we have some good policies too. So I want to just remind you that the so-called Obamacare or Affordable Care Act was a step forward in the way we deal with mental disorders. Now, we still have some stepping to do, right? We have to worry about what's going to happen to the Affordable Care Act tomorrow. There have been attempts to do away with it, by some people on Capitol Hill. But think about the three things that the Affordable Care Act is doing and could do even more so. The Affordable Care Act was meant to expand mental health and substance use disorder benefits and parity protection. That would affect 62 million Americans, 62 million, the Affordable Care Act. So when you hear people talking about the Affordable Care Act and what Congress is doing or is going to do, just think about what it was intended to do. I commend the people who, Obama and others, who were bold enough to commit that to law and to get people to support it in Congress and other places. Secondly, most health plans, and I'm saying now, but it's not now, it was then, had to cover preventive services like screening for depression for adults and behavioral assessment for children at no cost. That's a part of the Affordable Care Act. I don't know if you were aware of that, but you're probably going to hear more about the Affordable Care Act in coming days, and it's going to get all mixed up with the Supreme Court and the appointment of the next Supreme Court justice, because there are differences even in the Supreme Court in terms of how we deal with mental health in the health system. Here at the Satcher Health Leadership Institute, that's been one of our major projects. We have worked with states throughout the country in terms of monitoring the extent to which states are holding insurance companies accountable for their responsibility based on the Affordable Care Act. Based on the Affordable Care Act, there are certain things that should not be happening in terms of people being turned down for treatment, people not finding treatment affordable. We have to stay on top of this. I hope we can get through this next phase of Supreme Court appointment and things without sacrificing the Affordable Care Act. And I don't, I'm just saying that because I do think we made progress, but as you know, progress can be undone. If it sounds like I'm talking about the past, it's because in a way I am when I say that starting in 2014, the plans should not be able to deny coverage or charge more to patients due to pre-existing conditions, including mental illness. That is probably the most important component of the Affordable Care Act. There are a lot of people who have pre-existing conditions, including mental illness, and we should not sacrifice that, even in a country that does not assure that everybody has access to health care when they need it. We don't do that. We're one of the few countries left that do not assure access to health care. We still act as if how much money you have should be the determining factor of whether you get treatment. I think that day will end. I don't know how soon, but I know our goal should be for it to end. Well, I'm a physical activity enthusiast. When I was a student here at Morehouse College years ago, many years ago, I ran distance. I wasn't that good, but I did run distance. Then I got to medical school and I stopped running, thinking that I didn't have time. And of course, that's when the stress builds up and you're not dealing with it. So it was one day when I decided that I need to go out and run a little bit. And I've been running ever since. When I was Surgeon General in 2001, I ran the Marine Corps Marathon. And that was quite an experience. It was not the running of it that was the experience. It was the lifestyle of preparing for it. Physical activity is very important to mental health. The one concern I have about COVID-19, and the one that I have not obeyed, if you will, is the feeling on some people's part that you shouldn't go outside Ever since COVID-19, I have been continuing to walk or jog in the morning, early in the morning, because I just believe that physical activity is such an important part of our lives. So I'm not one who could stay home in the basement, and I don't believe that's the best approach. I think we need to, I believe we should wear masks, and I enthusiastically do that. We should do everything we can to prevent the spread of this virus from ourselves to others and others to ourselves. But I think it's important to be physically active. It's important for mental health, not just physical. Studies show that physical activity reduces depression, elevates moods. And I have a Surgeon General's prescription. Some of you have gotten my prescription. If you haven't, you can go on our website and get one of my Surgeon General's prescriptions. Studies show that physical activity improves mental acuity. Studies show that physical activity reduces stress and anxiety. I'm a witness. And studies show that physical activity improves sleep. So I recommend physical activity. When I was working with the Action for Healthy Kids program in Chicago, which I was involved in starting about 10 years ago, we were very concerned about the role of physical activity in the lives of children. And I certainly think that in schools, physical activity is very important. So it was a colleague from University of Illinois, whom some of you know, Chuck Hillman, who did these studies showing what the brain looks like after sitting quietly, as opposed to what the brain looks like after 20 minutes of walking. And as you can see, there's quite a difference, and the difference is in circulation in and to and in the brain. It's a very important observation that he made, that when we're physically active, our brain works better than when we're not physically active. I can give you a lot of reasons why you should have a regular physical activity program in your life, especially many of you who are so busy helping other people, and I appreciate that. But I also want you to take care of yourself. And that whatever physical activity you adopt, it doesn't have to be running or walking as I do, but you do need a regular program of physical activity. Well, I'm about to end and begin to respond to your questions if I left time for questions. I hope I did.
Yes,
In
you
order
did.
to eliminate disparities in health, we need leaders who care enough. That's how we choose them. When we're trying to decide which person to admit to our program, they've got to have demonstrated caring. We want them to know enough, yes. Want them to have demonstrated that they will do enough and that they will continue, they will be persistent. Well, I went on longer than I had planned because I still get very enthusiastic about these reports, and I think together we can make a difference. Thank you.
Thank you, Doctor. Thank you. On behalf of everybody, we have about 250 attendees, and on behalf of all of them, I want to thank you for your comments. And we have a whole half hour with you, so hang on to your hat here. First of all, I just wanted to say that your career and contributions around making sure we integrate mental health and physical health, that was no small thing. No Surgeon General had ever done that. Nobody at your level. It really, I remember at that conference, that became really the theme for the work we were going to do in our field, was to integrate and stop segregating. And you had a lot to do with that. So I want to thank you.
Thank you.
I just want to tell you that I appreciate your comment about physical activity, because, you know, that guy who sits in the basement is me. I have a treadmill upstairs, but it's kind of a coat hanger right now. So I really, hopefully you're giving me some inspiration to get upstairs.
Well, then I know I made a contribution here today.
There you go.
At least one.
So I loved your matrix, and just as background, our community, the people that are watching you now, are what we call the recovery, rehabilitation, consumer movements. And we came really to raise the bar from a purely medical model. We came to really look beyond illness and disease and diagnosis and a prognosis of a life sentence, and people would never be able to recover and have a full life. So we've been on that train for 40 years or even more. So I appreciate that. And I want to draw some parallels to your matrix, because I think there are some important ones. So in your matrix, you talk about productive activities, successfully coping with adversity, adaptability to change, and fulfilling relationships. And all of those really fit within the format I'm talking about. And they may not seem, we really want that to come across in that way. Psych rehab and peer support, we're about social determinants of health, looking beyond illness and diagnosis and medication. We're about exercise. We're about alternative treatment. We're about jobs and education. We're about successfully sort of getting ahead of crisis. We have a lot of tools for that. And we're very much about change. We talk a lot about change readiness and change support. So I just want to draw that connection, because it may not have seemed as clear perhaps to the audiences, that there's a real tie-in between your matrix and what we've tried to do around a whole person, social determinants, and alternative treatment. So my first question to you, though, is, did you work with Anthony Fauci when you were at CDC?
No, well, yes and no. I mean, Tony was director of the National Institute of Infectious Disease at NIH. And then, of course, as you might know, when I became Surgeon General, I actually lived on NIH's campus. And every morning when I was going jogging, I would meet Tony on his way to his office on his bicycle. So we've done a lot of things together. I have a lot of respect and admiration for Tony Fauci. And he's, I don't envy what he's going through right now, but he's going to stay the course. I assure you of that.
He does definitely seem sort of courageous on that. So this connection between politics and science, this is a terrible conflict we're in now, where the scientists, to my judgment, are not being listened to. Did you experience that, this tension between politics and science?
Yeah, I think I experienced it in different ways. But I was dealing with a different kind of attitude. President Clinton and I disagreed on some things, but there was a mutual respect that I will always appreciate. And I'm not saying it's just because I'm speaking at the Clinton Center next week, I guess, this week. But there are some people you can disagree with and continue to move forward. And then there are other people where, everything stops when you disagree. I said the other day, and I quoted Martin Luther King Jr., my first encounter when I was a student here, but he said that until a person finds something for which he or she is willing to die, then they're not fit to live.
Wow.
That's what he said. And it's amazing. Obviously it doesn't have to be about life and death, but certainly we have to be willing to sacrifice something for what we believe.
So you have really paid a lot of attention to race. And as you know, racism, violence, policing, these are front and center for us. We have had a terrible tragedy in Rochester you may have read about, Daniel Prude. But there are those tragedies around the country. And
well, by the way, just so you know, I did my medicine pediatric training at Rochester Strong.
Oh, did you? Well,
Yeah.
That's the hospital that evaluated him.
Yes.
But the question I guess I have for you is on the issue of race and disparities and inequities. I mean, you've studied that. You have a task force, I believe, you've set up that's expressly going to be looking at disparities. And do people of color, are they more subject to the virus and more subject to poor care and other kinds of disparities? Would you talk about that? Because race is a top issue for us. It's been throughout our conference. The word culture is very strong here, as you might see in our program.
Well, I was negligent in not talking about that because that's so important. I think the whole issue of the goal of eliminating disparities in health takes on new meaning when you deal with something like the COVID-19 outbreak, because the first thing you see is that people who have these pre-existing conditions, who have disparities so that they are more likely to be obese, more likely to have diabetes, more likely to have heart disease, then they're going to suffer more from COVID-19. We've seen that over and over again. You're at greater risk for COVID-19 and a lot of other things too. You know, if you are suffering from disparities related to your heart or lungs or what have you. So it's a real issue. And a good thing that could come out of COVID-19, of course, would be if we decided as a nation that we were going to get serious about eliminating disparities in health, that we were going to value the lives and health of all of our people and act that way in terms of the care that we provide.
How do you think we could do that? I mean, I think we're so much more aware of disparity, poor people, people of color, people with mental illnesses and such, addictions. But how do you feel like we can address that? You've watched this issue for a long time. You're studying it now. Beyond studying it, I guess, once we determine it's probably you're going to find out, this going in, that there's a high kind of inequity. How would we address that within the medical field and then just, in the country?
Well, I think the Affordable Care Act was a step in the right direction. I think in order to address it, we've got to make a decision that when it comes to health care, the amount of money you have is not going to determine your access to quality health care. Yet in this country, we're going to make sure that everybody has access to quality health care. And again, I know it's easier said than done, but if we make that decision, that's a major start. On the other hand, we found ourselves in a situation where we're trying to undo the Affordable Care Act.
Mm-hmm.
We have Congress and maybe the Supreme Court even declaring that maybe the Affordable Care Act is illegal or what have you. So we've got to fight. We've got to continue to fight for that. And by the way, I was negligent in not talking about social determinants of health. And I say that because I served on the World Health Organization's Commission on Social Determinants of Health for 5 years. It was an amazing experience, traveling all over the world, seeing how people's health was impacted by their income, all kinds of social issues. I tell the story that, I've overcome a lot, so I'm not complaining when I tell these stories, but it's true. I mean, Alabama was one of the places that had very serious problems in terms of race relations when I was growing up. And I remember this is in my book that was recently published, I remember saving money because I wanted to buy an ice cream cone. When you're small, 5 years old, I mean, things like that become really big.
Mm-hmm.
So sure enough, one day when we were in town, I slipped away from my brothers and went into the drugstore to get a cone of ice cream. And that's when the lady told me that, without repeating her language, that they didn't serve my kind. A 5-year-old kid, and this lady saying, "We don't serve your kind in here." That was that I would never forget that. I never understand it, but I would never forget it. And it's one of the things that sort of drives me when I think that people could be that cruel. And I know that it's a system thing. So when I got to Morehouse as a student, I was a very serious student. But when I heard that the students were organizing to sit in and so that you know, the stores that sold to us had to also provide opportunities for us. I dropped everything and joined that movement with people like Marion Wright Ellerman, whom I'm sure most of you know. Marion was a sophomore at Spelman. I was a freshman at Morehouse. But that was the beginning of my feeling like I could do something and not just feel bad about the way things were, but I could do something. And yeah.
So here's a question from someone in the audience, and it fits with what you're working. Oh, somebody put another comment in and pulled this down for me. Oh, I lost it. Oh, here it is. Do you think American people are getting an accurate count of who is dying from COVID-19 when it comes to race and culture? And I know that's part of your project. So I guess I'm assuming you think that. And then the question is, what is your strategy for determining that, quantifying it, and making recommendations around it?
Well, I don't think that.
No?
I think we can do much better than what we're doing in terms of monitoring this pandemic, not just in this country, but throughout the world. But I certainly think in this country, it's very important for us to find, and that was the essence of our proposal, you know, to DHHS, is that we would develop a system for monitoring this disease in different populations. And so we received a major grant from the Department of Health and Human Services to lead that effort.
You talked about, in your article, you talked about that there'll be essentially a mental health epidemic behind the pandemic. And we see that in the rising rates of suicide and of overdoses and trauma. So your prediction, as ominous as it was, has certainly played out. And as an aside, we just do not get support from the federal and state government to anticipate the amount of trauma and illness and struggle that we're going to be inheriting, not just now already, but just as people leave their houses and try to get back to work and all of that. Do you have any comments around just the unperfect storm of the virus and suicide and overdose, poverty, and discrimination? I mean, you know, we got a big wave sort of coming here, if it's not here already.
Yeah, we do, because there are a lot of people who need help right now who are not getting it, and some of them are not asking for it. They're just suffering. Some of them are getting in a situation where their relationship with their spouses or their children deteriorating. So no, I think we have a serious problem developing. So what the goal was to try to get people to become more attentive to what's happening to us, you know, in terms of relationships and self-care and all of those kinds of things. There are a lot of things happening because of COVID-19 that need attention. And so part of what we're doing as a part of our project is also trying to bring more attention to these things that are happening in our lives, to our children, to parent-children relationship, husband-wife relationships, and how that could affect us in the future if we're not careful.
When do you anticipate that report being available? I mean, you're just starting the process now, I imagine.
You're right about that. We're just starting.
Yeah.
Okay. No,
Well,
the people here only listen to me part-time now. You know, once you get to be my age, and they say, that's what you say, but we got to do the work. So I think we will have that information, begin to have that information within the next year or so, but I don't know how long it's going to take.
Great. I'm going to ask you one more, and then I'm trying to watch the box, but you know, I think insurance is one part of the equation, but even when you have insurance, in terms of discrimination, people of color do not get equal access to quality care. They're not taken seriously. People with mental illness too are discounted, not taken seriously. 5 hours in an emergency room, that's not happening with wealthy white people. So just any thoughts about, it's not enough to have insurance if the system does not give you equality and give you access to care and follow up. And one last thing is, a lot of people who are disadvantaged don't make it to the emergency room. We need to come to them. So just something around engagement, access,
Well,
fairness.
let me take your last point first, because that's something that's very important to us. I gave the example about emergency rooms, but community health centers, we've developed working relationship with community health centers. And so the model that I described for Grady Hospital is one thing, and it's very important. But just as important is the model that sort of binds community health centers together and allows them to provide better care to patients. And one community health center may be strong in one area, stronger than another. And so that's been a part of our strategy. I believe there are 11 community health centers that we're involved with here.
Okay.
With the idea being that we can improve the quality of care, and that in many ways, community health centers are better suited to provide much of this care. And I know that many of you work as social workers, community health workers, and there's an opportunity to make a major difference in the lives of people.
Thank you, Doug. So we have room for a couple of questions. I don't know who's monitoring the chat box beside me, but does anybody on staff have a question that you've read from the chat box?
Harvey, this is Len. There's a question from the chat box that says, does the U.S. Census help with funds to help with these programs?
Very good question. I don't know that the U.S. Census does, and I could be wrong, it may well be, but the funds that we receive are part of the budget of the Department of Health and Human Services, especially the National Institute for Minority Health and Health Disparities. That's where most of these funds come from. Whether or not the Census Bureau provides any funds, I don't know. I could be wrong. They may well provide some, but our funds all came from the Department of Health and Human Services.
Any more questions, Len or others? So while we're waiting, let me put you on the spot and ask you to be a prognosticator in terms of the COVID. You've helped eradicate or restrict, some fatal sort of conditions in the past. You've seen them done. You've been part of it. What do you think is going to happen here? What is it going to take, and how long will it take?
I wish I could comfortably answer that. And I remember when on the same day, they asked Anthony Fauci and me the same question about vaccines. And I said I thought we'd have a vaccine by the end of the year. Tony said that he thought we'd have one by next year.
Wow.
And so, but anyway, it's going to turn out that we were both right or we were both wrong. But I think things are moving much faster than we thought, mainly because of the investments that we're making. It's hard to know though, because nobody anticipated the problems that we've had with vaccines. If things go wrong with the vaccine and one person becomes ill, you have to stop the whole thing in many cases, and because you can't take the risk. So it's complicated, but I do believe that because of the investments that we've been making, that we're going to move much faster than we usually. What do we usually take 3.5 to 4 years to produce a vaccine? And I don't think it's going to take anywhere near that amount of time because we're investing more and we've learned a lot already. We do need to take the politics out of it if we can do that.
Absolutely. Well, Len, any more questions? Or are we winding down?
Actually, I'd like to follow up with what Dr. Satcher just said. How are decisions made, and to being sort of on the inside at one time, how are decisions made about which vaccine? Because there's a number of companies that are doing the research and at different stages. So how does that get done?
Well, I think what's measured is a combination of safety and efficacy. And it may well not be just one vaccine, but certainly whatever vaccine is chosen, it has to provide the optimal safety and efficacy in terms of dealing with the virus. Now, this is very complicated because it's not easy to determine that in a few months. You have to follow a patient a long time to be comfortable that this vaccine is better than that vaccine. And it might well be in this case, because I don't think we've ever done this before, engaged this many pharmaceutical companies, Pfizer, Johnson & Johnson, on and on, major companies. And it might well be that we would end up with more than one vaccine that's safe and that works. And so don't be surprised if that's the case. The main thing you want to do is to make sure that the vaccine is safe. And it might well be that some vaccines work better in some populations than others. We haven't included any children in these tests, and probably for good reason. But when the vaccine is ready, we certainly have to deal with how early can we safely immunize children.
Great question, Len. And a closing one there. So Dr. Satcher, on behalf of all of us here, really want to thank you for your time, your work, your career in paying attention to behavioral health and holistic health. And so we look forward to hearing about your report on the health disparities. I'll be expecting a phone call from you in about a year or so.
Yeah, if you get a chance, you ought to buy my book. I'll even send you, I'm going to take that back. I'll send you a copy of my book signed.
Well, thank you, sir. Okay, folks, we're going to wrap this one up. I guess I'm going to shut this down and leave. Am I right, Len?
You are correct.
Okay. Thank you, Doc.
Great being with you.
Thank you.
Okay. I'm going to leave.